And get started. We're going to record, so everybody can click OK for the recording. Welcome to the Bay Area Breast Cancer Forum. I'm Hope Rugo, a breast medical oncologist at UCSF. We are going to talk about updates from the American Society of Clinical Oncology meetings, focusing on various aspects of breast cancer tonight. Our host and organizer is Melody Gaulu, who's there. I think you can see her on screen, and she's really important to know because she sends out the emails and has all the information. I wanted to let everybody know that we do take a summer break, and although it's kind of a funny break this year because it used to be because we couldn't meet in person, but now you could come from anywhere. Our next forum is slated for September 29th, right at the moment. And with me tonight and donating their time for this really nice forum is Michelle Melisko, breast medical oncologist. Natalie, you want to raise your hand when you can see, everybody can see your name. Natalie Marshall, breast medical oncologist, who's running our breast cancer clinic satellite in Berkeley, which is a great addition to our program, and also has a clinic at the Cancer Center in San Francisco. Michael Alvarado, surgeon extraordinaire, breast surgeon, and then Theresa Chan, who's also actually already a surgeon, but who's doing already completed her training in surgery, but who's doing extra training in breast surgery to be really excellent. So we have a great group, and actually Jo Chen will also come and join us in a little bit after she gets her family settled this evening. So actually we have some really exciting discussions to have, and we'll put your Q&A, there's a Q&A button there, so please put your questions and answers into the Q&A button, and we'll try and address them as we go along. One question came in about metaplastic breast cancer. We'll hold that until we get to the information on triple negative disease, which we'll talk about when Jo Chen comes and joins us. So we're actually going to start. There was actually a lot of exciting data at ASCO this year. I think the biggest was a plenary session with a PARP inhibitor for patients who have BRCA1 and 2 mutations. We'll talk about it in a little bit. But I think that what we'll do is start with an area for early stage breast cancer from Michael Alvarado, talking about a gene signature that could help understand which patients could avoid radiation for early stage breast cancer. Michael, you're on.
Thank you so much. Thank you, Dr. Rugo, for having me, and it's wonderful to virtually be here. And as Dr. Rugo was stating, so this was an abstract and some work that was done really looking at women that have early stage breast cancer. And as you probably know, when women undergo lumpectomy, most women get offered radiation to the breast to lower the risk of the breast cancer coming back. And so the question has always been, are there women that would do well without radiation? And there has been a fair amount of data in the medical literature showing that women over the age of 65 or over the age of 70 with small breast cancers, and really fine-tuning it to identify women that would actually do pretty well without radiation. But the question really is, can we widen that or broaden that concept to potentially other women, not just based on age, but different ages and different types of breast cancer? So I'll go ahead and share my screen and show you the slides that were presented, if that's okay. And here are the slides from the ASCO here that you can see the lead author, Dr. Sjostrom, and the rest of the group. And the title here, as you can see, Discovery and Validation of a Genomic Signature to identify the patients that might be able to undergo lumpectomy without radiation. And so we'll just kind of go through that. So here you can see, again, the clinical problem, as they stated, that adjuvant or radiation after surgery for lumpectomy is usually given. Women with a low risk of recurrence could potentially forego or not have radiation. And so their aim was to identify these women using a new molecular analysis. And so when we talk about molecular analysis, I think probably most of you know of or have heard of things like the MammaPrint genomic assay or the Oncotype genomic assay. So really now looking potentially at a genomic assay to identify women that will do well without radiation after lumpectomy. And they are calling this the polar data. And they had previously looked at women with a high recurrence score. So they do have some data looking at high risk patients, but they really here we're looking to identify low risk patients. So they utilized a set of data or some clinical trial data that was done a number of years ago, well over 20 years ago, where women with early stage breast cancer that got lumpectomy were randomized to either radiation therapy or no radiation therapy. And this was an early trial to do exactly what the question is today. Can we identify women that would do well without radiation? However, that trial didn't really identify a subgroup of women that would do well without radiation. But now that you have all the outcomes for those patients and you know what's happened to them, you can go back, take that genomic assay, just like we do with Oncotype and MammaPrint, run it on those tumors, and re-stratify patients based on the genomic assay to see, can we identify a lower risk patient population? Now, there are some caveats to this data. This is the first one that they've looked at. One of the issues is that most of these women did not get tamoxifen therapy or chemotherapy. So there's some caveats to it, but it is a very nice data set to be able to use to basically discover the gene analysis and then do an early validation of it. So they developed the genomic assay with these patients. As you can see here, they utilized about 350 patients to identify or come up with the gene signature or the fingerprint, the genomic fingerprint. And then once they had that, they went back and looked at the women in that trial to see if they could re-stratify those patients. And so here you can see of the women in that clinical trial, there was about 500 in the clinical trial. But here you can see what they did is they took almost 200 women that had lumpectomy and no radiation. And now what you can see on the right-hand side is that when you run this new genomic fingerprint or signature, the genomic assay, you can see that it classifies women in high risk of it coming back in the breast versus low risk of it coming back in the breast. And so these are all women that have not gotten radiation. So it does appear that this is able to identify women and stratify based on risk of it coming back. And it shows that the women that were in the low risk group have a very low risk of it coming back without radiation therapy of only about 7%. So that's kind of the initial validation, to validate what that gene signature showed. Now, what's important is that this genomic assay or this gene signature actually works better than the standard things that we usually use, like grade, patient age, tumor site or tumor size, and then also something called subtype, these things that we refer to as luminal. So strongly estrogen sensitive and strongly progesterone sensitive would be the luminal A. And then the possibility that there might be a slightly higher risk for those that are luminal B, which would be estrogen sensitive and typically progesterone not sensitive. So again, it's kind of a loose definition, but these in this graph, you can see these are the kind of characteristics that we usually use to try to identify low versus high risk. And they don't work very well, as you can see, or as I'm telling you, and they don't work as well as this gene signature. And as as all three, Dr. Rugo, Dr. Marshall, and Dr. Melisko would say, this is very similar to the Oncotype score or the MammaPrint score, because it does better than standard pathology and clinical characteristics. So again, great data in this initial consort of women that got no radiation. And then the question was, what if we look at all women in that trial, those that had radiation or didn't have radiation? So now what you see is that in the women that were randomized to radiation therapy or no radiation therapy, you can see that the low risk women on the left side, those that are defined by low risk with this new gene signature, whether they got radiation therapy or no radiation therapy, those outcomes were very similar. So it appears that radiation doesn't maybe benefit them that much. They already have a low risk of it coming back, and the radiation doesn't really appear to do much for them. So that's identifying what we'd really love to identify: women that can have lumpectomy and do well without radiation therapy in the future. On the right-hand side, you can see those women that have the gene signature or the fingerprint of their tumor that shows them to be high risk. The radiation has a very large benefit. And so that would be the population of women that you would want to target to see if we can lower the risk of it coming back. So again, this is something that people have been working on for 20 years or more, as you've heard in other forums with these medical oncologists and others, that the Oncotype and MammaPrint have been out now for 15 years or more, and that's really made a huge benefit in identifying women that can maybe not need chemotherapy. And so now the radiation oncologists, along with medical oncologists and surgeons, maybe can start looking at identifying women that will do well without radiation. And again, the one of the caveats here is that this is even without the standard, what we call systemic therapies, like the anti-estrogen like tamoxifen or chemotherapy. So probably on the left-hand side, those women that are low risk probably even do better when they're getting the standard hormone therapy that they didn't really get in this trial. So I just talked about the limitations, but their conclusion was that this genomic signature called POLAR might identify patients that have a low risk of the breast cancer coming back without radiation after lumpectomy, and that there may not be much benefit for those patients. And so that would be great if we could identify those patients. And we'll look forward to hopefully having them show more data in the future.
That's really interesting, Michael. Thanks for sharing that. I think the whole goal of trying to de-escalate therapy for patients who don't need more is so incredibly important. And so we'll look forward to more information about that. There was one question, just brief question, about whether or not this would change your choices about lumpectomy and radiation versus mastectomy in a particular patient.
Yeah, so that's a great question. And I think, as the whole panel knows, that we do have those discussions sometimes where women really don't want radiation. For whatever reason, they decide that they'd prefer not to have radiation. And we do our best to say, well, based on, lumpectomy, most women need it. And so a lot of times women just choose mastectomy. But here, if the patient comes and says, I'd really like to avoid radiation, maybe we can run this genomic assay on the biopsy that they had. And if it comes back low risk, we might be able to say, oh, well, here you go. You can have lumpectomy and have a very low risk of it coming back and avoid radiation. Whereas if that gene signature comes back high risk, maybe that patient says, I really don't want to do the radiation. I know I don't have to have mastectomy, but I think I'm going to choose mastectomy based on that data. So that may be something in the future for sure. It's a great question.
Yeah, it is really interesting. I think that we might be able to do that. Of course, we're going to need more data, and we're not quite ready for that yet. I think what I'll do is go on and talk about the Olympia trial, and then we'll go on to other presentations. And I'll just briefly mention the other one. So presumably everybody can see this now. This is the Olympia trial, phase 3 trial and at ASCO, we have these oral sessions where they pick the best abstracts to be highlighted for early and late stage breast cancer. But then they also choose the very best of all of the abstracts across all of the cancers to be presented at what's called the plenary session. And Olympia was chosen as a plenary session, and this data is also published in the New England Journal of Medicine. So let's see if I can make it move. There we go. Okay. And one of the cool things about this randomized phase 3 trial, meaning that it can be used to get drug approval, is that it was a collaboration between both pharmaceutical companies as well as groups that are nonprofit and do clinical trials. And that's some of these things here: the Breast International Group, a group in the US called NRG, and the National Institute of Health also played a role, as well as AstraZeneca, who makes olaparib and markets it with partner with Merck. So this was a trial that enrolled all over the world. So I won't go through that in detail, but lots of groups participated in this trial. The whole rationale, and I'm just going to put these through is that basically, and this is a really complicated slide, but you know that, now we test women up to age 60 who have triple negative breast cancer and women who have hormone receptor positive disease and a family history and variety of other characteristics, family history of ovarian cancer, et cetera. We look at germline, meaning all of the cells in your body have that mutation. And mutations in BRCA1 and 2 have been associated with a high risk of developing breast, ovarian, and other cancers. And what happens is that you lose a pathway that allows you to repair DNA. But if you block the other pathway with a PARP inhibitor, you can actually cause the cancer cells to die. So they call that synthetic lethality. That's up here, killing cells with drugs. That's what that means. And so there are 2 PARP inhibitors that are approved for treatment of metastatic breast cancer associated with a germline BRCA1 or 2 mutation. One of those PARP inhibitors is called olaparib and one talazoparib. Both of those drugs, compared to standard chemotherapy, showed a better response and a longer duration of response, but they did not improve survival. The survival was the same, meaning that you could get another chemo afterwards, and although you had another treatment option, you weren't living longer with your disease. Maybe in the very untreated metastatic setting, but we don't know for sure. So of course, then the interest is to try and understand if you gave a PARP inhibitor for a specified period of time to women and men who had breast cancer that's high risk for recurrence and had a BRCA1 or 2 mutation that they inherited, would we be able to change outcome in those patients? So the Olympia trial actually randomized women who had known BRCA1 or 2 mutations, had HER2 negative disease, so it could be triple negative or hormone receptor positive, and who had cancer remaining after neoadjuvant therapy. They had some additional criteria for hormone receptor positive disease. So you got chemo for at least 6 cycles, you still had cancer at the time of surgery. Or patients who went to surgery first, we don't like to do that too much, but it does happen, and had a lot of cancer, 4 or more positive nodes, hormone receptor positive, or any positive node, or a tumor greater than 2 centimeters if triple negative. Patients, almost 2,000, so 1,836 were randomized to get olaparib twice a day for 1 year or placebo twice a day for 1 year. If you had hormone receptor positive disease, you got hormone therapy too, and you received radiation therapy as standard. And what they showed actually, so I'm not going to go through the statistics here. I didn't take these slides out, sorry, but it took a long time to enroll patients in this trial. And BRCA1 and 2 mutations aren't that common in the population. Even though this was an international trial, it took 5 years to enroll the patients into this trial. The median follow-up now is about 3 years. So they've been following these patients for a median of 3 years. What we know is that most of the patients, 3/4, had a BRCA1 mutation, and a little less than a third had a BRCA2 mutation. And then patients were relatively younger because that's common with BRCA mutations. Triple negative disease was seen in 80% of the patients. Only 18% had hormone receptor positive disease. And some of them might not have been hormone receptor positive because they're testing them centrally to see if it's really true or not. About half of the patients got their chemo before surgery and half afterwards. And then patients who had hormone receptor positive disease, most received hormone therapy. And then we're going to skip through this one here. So the big, of course, question was, did you help people live without an invasive cancer recurrence or a new cancer? So this is called invasive disease-free survival. And what you can see here is that in orange are the people who took a year of olaparib, and in blue are those who took placebo. There were less invasive events if you took olaparib for a year, and the absolute difference was almost 9%. So an additional 9% of patients didn't have an invasive disease event if they took a year of olaparib. Really very striking. And what you can see here is, here's the number of events that occurred, 178 versus 106. It gives you another idea about that. Remember, it's only 3 years, but that's good for triple negative disease. Then the question is, what happened in terms of having, let's see, we're going to go to this one. What happened in terms of getting a metastasis? So an invasive disease-free survival could be a new cancer in your breast too. But we want to know if we could actually reduce the rate of getting incurable cancer, metastatic disease. As you can see, the 3-year distant disease-free survival, so that means a metastatic focus, was better if you took olaparib than if you took a placebo. And the difference, the absolute difference, was about 7%. So that's actually big for our studies. I know you like to see 20% or 30%, but 7% is really big. We have a lot of treatments that we give where the benefit is 3%. For example, the CDK4/6 inhibitor, the data so far suggests a benefit of only 3% in distant recurrence if you add it in high-risk hormone receptor positive breast cancer. Here, the difference is 7%. So a very, very big difference. The overall survival is still early. There's a numeric difference. There are less deaths in the patients receiving olaparib versus placebo, but it needs more time to get enough events to really make it what was called a significant difference. Now, one of the big issues is whether or not it made a difference which kind of mutation you had, BRCA1 or 2, whether it was hormone receptor positive or triple negative, and everybody benefited. Some patients get platinum, carboplatin most commonly. It's still not clear whether or not if you had prior platinum, you benefit less or not, but it wasn't convincing. So anyway, everybody seemed to benefit based on this information. You always want to know what the side effects are when you treat a patient with a new drug. And this shows you that anemia was the biggest side effect. About 5% of people needed transfusions of red blood cells. But 4% of only needed one transfusion over the whole year. Anemia is a known side effect of olaparib. Some fatigue, some nausea, low blood counts wasn't really a big problem. So that's the biggest issues with these agents. The other thing that's concerning is if you blocked all pathways of being able to repair DNA, would you get other cancers? Would you get leukemia? This has been an ongoing question in ovarian cancer where these agents have a longer track record. It's very encouraging to see that this is the leukemia here. It was no different number of leukemia cases. This is the background population in patients treated with placebo versus olaparib. That's very encouraging. And there was no difference in new cancers either. So that's great. And most people were able to complete the whole year. Only 10% stopped early. So that's very good. And then they also looked at global health quality of life. And you can see these curves are right on top of each other. Even if you were taking a drug that can cause nausea and anemia, you actually felt pretty much the same in terms of all of the criteria we look at. So that was actually really encouraging. So this actually changes the treatment standard for patients who have BRCA positive breast cancer that's high risk or have residual disease after neoadjuvant therapy. It's a big impact. And this figure here is a QR code. And if you take a picture of it with your phone now, it will actually lead you to a plain language summary. And that link also is available, but I'll leave it for a minute while we talk. There was also another study I won't show, but where patients who had BRCA1 and 2 mutations were given another PARP inhibitor, the other one, talazoparib, for 6 months prior to surgery. And what was really interesting in that study of about 60 women is that 45% of the women had no cancer in their breast or node at the time of surgery. That particular trial called neoadjuvant talazoparib treated only patients who had triple negative disease, not hormone receptor positive, who had BRCA mutation of any kind. So I'm now going to go off of this here. One thing I'll just mention is this beautiful woman, Valerie Kaufman, is a colleague from Israel who died of metastatic breast cancer, but lived actually for 15 years with her disease. She was the co-chair of this study. So The remarkable aspect of the Olympia trial is that you could give an agent that's targeted to something we know is in your genes, and you could really change outcome. There actually is another mutation called PALB2 that's in the same gene as BRCA2, and those patients can respond to PARP inhibitors who have metastatic disease. So there's been a question about whether or not we should treat patients the same way in the early stage setting. One of the questions that was sent to us, Michelle, was if you had a patient who had high-risk disease who'd taken capecitabine, Xeloda, that we commonly give to patients with residual disease after neoadjuvant therapy who have triple-negative breast cancer, patient is now a year out from their surgery, would you consider giving olaparib in a patient with a BRCA mutation? You're on mute.
Yes, so I saw that question, and I think this is it is actually really challenging in the sense that, of course, in the trial, they selected a fairly high risk population. There was sort of a time defined period after surgery which they could go in, and we know that in triple negative disease, a good majority of high risk patients who recur are going to recur early. Within the first year to 2 years, those highest risk patients, probably within the first year. And most of the high risk patients will have eliminated most of their risk by year 3. So, one does wonder if someone is already a year out from, their surgery, they've completed 6 months, where do you draw the line and say, okay, this patient already, their risk by the mere fact that they haven't recurred yet is low enough that we wouldn't offer it. And I guess, my feeling is that most of the patients that I see that we see tend to be fairly risk averse, are willing to be tolerant of, tolerating the kind of risks and the kind of toxicities that we see. So I would probably be more generous and say, yes, if someone finished 6 months of Xeloda, they're in their first year from complete, surgery, maybe into the second year. Of course, the day after that presentation, I had someone who, is triple negative breast cancer, BRCA1, and she's, 4.5 years out. I mean, I've been telling her that I feel like she's likely cured at this point, but so I'm not going to offer it to her because she has a lot of other health issues, and I don't think she's going to do well with it. Where I'm going to draw that line, I mean, I'm guessing probably, I would certainly within the first year, yes. Between years 1 and 2, probably, and then beyond year 2, it's going to have to be a dependent, I don't know. That's my thought, is it's an art. Medicine's an art.
Yeah, I think it's actually really interesting because for hormone receptor positive disease, which represented only a quarter or so of the patients, you could potentially see a benefit even giving the drug many years out. We just don't know, and we won't know. I mean, that will never be studied, but I think it's a fascinating question that may be discussed as we start looking at cell-free DNA blood testing to try and determine what kind of treatments we're going to give. One of the questions that came in was about whether other germline DNA damage repair genes could potentially be treated with these agents. And the only data we really have on that is a trial Nadine Tung did called olaparib expanded, where patients who had PALB2 mutations responded to olaparib, but the other mutations did not. So I don't think it has implications yet for early stage disease because we don't see responses with other mutations to PARP inhibitors. And then another question was about olaparib added to a CDK4/6 inhibitor. I'm going to ask you, Natalie, about sequencing, but you cannot use olaparib plus a CDK4/6 inhibitor because of the bone marrow suppression. So they cannot be given safely together. But Natalie, if you had a patient who had high risk hormone receptor positive disease and a BRCA mutation, how would you sequence potentially if abemaciclib Verzenio gets approved? How would you sequence olaparib and Verzenio?
That is a really hard question. I would probably give the PARP first. That's what I would probably do, because the benefit is much higher than the benefit that we've seen so far with abemaciclib, and we don't have long-term follow-up with abemaciclib.
Yeah, I mean, I think that what you answered is what people have answered on large panels I've been on in the last 10 days or so since ASCO. And the idea being that hormone receptor positive disease can come back for a long time. So you could sequence by giving the year of the olaparib and then give 2 years of Verzenio if it's approved, and you would be okay. So I think many people agree with you on that one. Another question just came up about whether you would consider using olaparib in patients with lower risk BRCA positive disease. So, a smaller tumor, one positive node, hormone receptor positive. How much will we expand the use of PARP inhibitors? Michelle, do you have a sense for that?
I guess it goes back to the question, just to the comment I made before, like, just like we don't know with the, with the time duration, would we what about, is there a chance that we could see benefit in patients that were triple negative that had a path CR, even, if 10% of those, even, those patients have a great prognosis, but, 9-10% of them may recur, and those recurrences might happen early. So could we bring that down to 3 to 4, could we bring that down by 3 to 4%? Patients would probably buy into it. So I think, the answer is, I think that for someone who is triple negative disease, neoadjuvant treatment that had a past CR, I would probably not, honestly. I think that we have to wait just a little bit longer to see how much, if there are any other emerging toxicities. If someone really said, I want to do anything, I'm willing to accept toxicities. But I think that, one of the more challenging questions is, what if someone making the choice between Xeloda and this, for someone with a little tiny touch of disease, I think that, again, just like we talked about the CDK4/6 inhibitors, this data seems to be better than Xeloda. So for a little touch of, I might do the PARP inhibitor first and then Xeloda.
Yeah, I think I would use the PARP inhibitor instead of Xeloda, but
it's not clear that Xeloda. I don't know if they actually added. How many patients in this trial?
None.
I don't think anybody got Xeloda, right?
No, none, yeah.
Yeah.
So Michael, would you be enthusiastic about testing neoadjuvant PARP inhibitors in patients with BRCA mutations?
This Michael?
You're the only one.
I think so. There's been a big push for all sorts of genetic testing of women, of all women. There's a big movement for that on all aspects of germline mutation status. So I think, I would be open to it for sure.
Yeah, I think that the idea of de-escalating therapy is really interesting. And so one thing that I-SPY, as it expands, it will look at, we hope, is a PARP inhibitor as a way to try and differentiate who needs more and who needs less. The whole idea that you would, I know that I've been told de-escalating is a bad word, but we seem to be stuck with it. But I think the idea being that you could personalize therapy based on response to treatment. And I think that's kind of cool. Like you could give a 3-month induction and see what happened with a PARP inhibitor. And that would be, I think, quite interesting. So we'll see what happens. Then the question is how long you give the treatment for and things like that. We still need to answer questions about it. And some people do have more side effects than others. So we'll see what happens as we move forward with this. There's a lot of studies going on looking at immunotherapy combined with PARP inhibitors in the metastatic setting. So I think, we'll hear more from Joe Chen a little bit later about one immunotherapy trial that was presented at ASCO, but we have heard a press release about a study that gave pembrolizumab or Keytruda before and after surgery to complete a year. So one of the questions has come up about whether or not in that setting you would add olaparib if that treatment is approved. The press release suggests that it was better than not giving pembrolizumab. So that's going to be a whole nother question too that we'll have to answer in the future, the subject of much discussion. The other thing just that Michael mentioned is there's a lot of discussion about now who should be tested. Because of the Olympia results, there's strong support for testing anybody with triple negative breast cancer and patients who have hormone receptor positive disease with just about any feature that would suggest a mutation, and certainly women under the age of 60 for sure. So I think that we will see an expansion of testing. So let's move on and talk about, I think, HER2 positive disease next. Natalie, you had some interesting topics to discuss. Be sure to unmute. Are you there?
Yes, I'm
Wonderful.
trying to get everybody out of my view here.
You click the single line
Yeah,
on
I
the
got
top
that.
of the pictures.
Okay, so I'm going to try to give you guys.
First, go
there
into
there
slide
go.
presentation.
Yeah, so can you guys see that?
Yeah, we can.
Okay, so I'm going to talk about a study from China from Yuan et al. And they looked at trastuzumab or Herceptin plus endocrine therapy or chemotherapy and trastuzumab as first-line treatment for metastatic breast cancer that was hormone positive and HER2 positive. So this is the outline of the trial. Patients had to have basically triple positive disease or hormone positive, HER2 positive disease, and a disease-free interval of greater than 12 months from the time of their completion of their adjuvant treatment. And they were randomized 1-to-1 to endocrine therapy, which could be all types of endocrine therapy. It could be tamoxifen or SERMs. It could be aromatase inhibitors. And they were randomized to that plus trastuzumab or chemotherapy and trastuzumab. And it was those three types of chemotherapy. And the endpoints that they were looking at were progression-free survival and overall survival, as well as overall response rate and safety. So these are the key inclusion criteria. And this is kind of like standard for most of our trials. Patients have to have a good performance status, adequate organ function, and be over 18 years of age. The baseline characteristics were very balanced between the groups as far as the ER and PR status versus ER or PR. So some patients that were included may have only progesterone receptor positive disease. The premenopausal patient cohort was the same in both groups, in almost 60%. Visceral involvement, so that means like involvement of the vital organs such as the liver or the lungs was balanced, and the number of sites of metastases was balanced. And what it showed is that the progression-free survival and the overall survival in patients receiving endocrine therapy plus trastuzumab or chemotherapy and trastuzumab, that the endocrine therapy and trastuzumab arm was not inferior to getting chemotherapy for progression-free survival and overall survival. So when they say that, what they really mean is that it's not worse, at least in this trial, for its length of follow-up. And one of the things that they did see in the subgroup analysis, where they're just looking at the different groups, is that patients that had a disease-free interval of less than 24 months prior to going on the trial did worse with endocrine therapy and Herceptin, and chemotherapy seemed to be better for them than those that had been under control for greater than 24 months. And these were the adverse events. These are kind of expected that the chemotherapy group would have more adverse events than the endocrine therapy group. So more low blood counts, more mouth sores, fatigue, nausea, and vomiting were seen in the people getting chemotherapy. That would be expected. So now, how to put this into kind of line with what we in the United States consider the standard of care for first-line treatment, which is coming from the Cleopatra study, which is using docetaxel plus trastuzumab. And this trial, the Cleopatra trial, which has mature data, has shown that there's a progression-free survival advantage, but there's also an overall survival advantage. So this is really the standard of care for metastatic disease. And what's important about it is that in both ER positive and ER positive and ER negative disease, in both groups, this overall survival benefit holds. So this is really our standard of care in the United States. And so, trying to put this in balance with our standard of care versus using something that's as Dr. Rugo says, de-escalated. So it might be that avoiding chemotherapy could be appropriate for some patients with ER positive, HER2 positive disease, and it's definitely better tolerated. Now that we have a subcutaneous trastuzumab, it's called Hylecta, and what that is Herceptin or trastuzumab that can be given by a little injection in the leg every 3 weeks. So endocrine therapy plus that would be like something that's not even infusional. So the quality of life could be better for patients with metastatic disease. And I think that optimal HER2-directed therapy in the first-line setting, we really still probably feel that chemotherapy with trastuzumab is the best, but this would be an alternative that would be reasonable probably in some patients. So we don't know about overall survival advantage with this program. I think it will have to be followed out over time. But I think it's just an interesting study for de-escalation of therapy and maybe offering an alternative to chemotherapy for patients who might have multiple medical problems or maybe don't want to undergo the toxicity of chemotherapy. It's a good alternative.
So great work, Natalie. I think to sort of summarize the overarching is that this trial in China looked at the standard, which is giving chemo and Herceptin versus hormone therapy and Herceptin, essentially. The problems are that the chemotherapy partners aren't what was studied, and the hormone therapy was all over the map. And they didn't use the other antibody we standardly use in metastatic disease because people did better with it, pertuzumab. So there were issues with it. I think it's an intriguing question, I agree, but it's problematic. And because we have seen a survival benefit when we give docetaxel or Taxotere or Taxol with Herceptin and Perjeta as treatment in the first line, first treatment for metastatic HER2 positive breast cancer. And some women are still well 8 years later, which is the longest follow-up. It's kind of hard to get rid of that, but I think it really plays a big role in helping us understand maintenance therapy. So a way, what should we do after we give the initial chemo? We feel much more confident with the hormone therapy added to the antibodies because this is so nice. I mean, I think you could potentially talk to a patient who had like a node and was 75 years old and didn't want to get chemo first. You feel comfortable based on this data. I don't know how one would really think about it other than that.
Yeah, I guess and Michelle, you can tell me what you think too. I wouldn't feel comfortable for this with somebody with visceral disease that's younger, who I think would tolerate 6 cycles of docetaxel, Herceptin, Perjeta. I would want to give them treatment with chemotherapy in order to get things under control and maybe use maintenance therapy with hormone blockade. That's kind of how I approach it.
Yeah, I mean, I think that's kind of always been, certainly the approach for a younger patient, but I feel like anecdotally, I've had several cases, and it was actually more by, not really by my choice that I couldn't start chemotherapy. For example, a patient that presented with very destructive bone mets, and as well, she also had liver and other, primary breast cancer. She presented with de novo metastatic disease, and she had to go to surgery. She had this huge spine surgery, and so we could only start Herceptin and Perjeta, and her cancer melted away while she was recovering from her spine surgery before we could give her her first dose of chemotherapy. And she came in, 6 weeks later and said, do I really need to do that chemotherapy? She was still recovering from this big spine surgery. And I said, we'll watch it. And, we just kept watching, and her tumors just kept shrinking and shrinking. And in those cases, I think there are patients, she's now, 4 years on antibody therapy alone. So there are some patients whose disease is just going to be exquisitely sensitive, but you don't know who those people are. So I wouldn't voluntarily have made that choice. But I think that it's
like that too, Michelle.
Yeah. Yeah. I mean, and I've had patients that have been, presented with very similar, again, it's often these de novo metastatic patients, not people who have, have had HER2 positive breast cancer in the past and recur. So I think that I'm excited about this. I think that it's definitely something I will consider. for patients, I will, but probably not someone who shows up with a 6-centimeter liver met.
Yeah, I think that's, you could use it and think you could still give chemo and get the survival benefit later. You just don't know. I'll point out that Natalie mentioned about Hylecta. There's also another combination called Phesgo, which was more recently approved, and that's Herceptin and Perjeta given as a subcutaneous or under the skin injection. We actually have been giving it at home in a pilot trial that was funded by Roche during the COVID pandemic that's still continuing. One of the questions we got was whether or not you could self-administer Hylecta, which would be so great. But right now we don't do that in the US. I don't know that we're going to anytime soon, but it is being done self-administered in some countries in Europe. For example, I know in Spain that patients self-administer, which is kind of interesting. This is a fascinating, I think, presentation. And somebody was also asking why they didn't give Perjeta, and it's kind of too bad. These studies are started, it was like before 2015. I mean, it was really a long time ago. And so they didn't have Perjeta in China until last year. So they certainly weren't going to be giving Perjeta. And then that's one of the reasons why I think they give all different chemos, but I think it's really interesting. Good to hear your perspectives on that. So maybe we'll move on and have Rachel talk about, let's see, I'm going to have you do that in a moment. That we actually have a couple of really interesting presentations. We'll have Rachel talk about, Theresa, sorry, talk about psychosocial outcomes in surgery. And then we're going to talk about a really cool poster about muscle mass in young women. So Theresa, you're on.
Great. Let me just share my screen here.
Not Rachel, but Theresa, it just shows you. People call me Ruth, so I have an
Right. Can everyone see my screen? Is it just a
Yes.
single screen?
Yeah, you could hit it again as presenter and you won't see both of them because we're seeing both right now.
How's that?
Better, great. Now just presenter mode.
For some reason it's just, all right.
Well, you're okay, I
All
guess.
right,
Nice.
I'll just do it in this format. Sorry, I can't get my technology to work. Well, I thought I'd present an abstract today that looked at the impact of patient tumor and treatment factors on psychosocial outcomes in invasive breast cancer presented at ASCO. I think it's important to look at how patients are actually experiencing their cancer treatments and their cancer diagnoses. I think a lot of times as physicians, we focus a lot on our benchmarks in terms of overall survival and recurrence. But we still need to gain that understanding that patients can offer us into their well-being and their experience with their cancer. So in this abstract, the investigators were actually in Toronto, and they administered a couple different surveys to patients at different time points. And they work also at an academic center in an urban environment, very much like UCSF. And they polled women diagnosed with stage 1 to 3 breast cancers between 2014 and 2017. And they asked them these questions at different time points in their treatment. So before surgery, 6 months after surgery, and then 12 months after surgery. And after collecting all of their data, they looked at different factors such as the type of surgery, the type of tumor, whether they're estrogen or progesterone receptor positive, HER2 receptor positive, whether they received chemotherapy or endocrine therapy, and also whether they received radiotherapy, just to see how they were doing at those different time points and what their experience was. So in looking at the results, looking at their psychosocial scores according to their surgical procedure, what was really interesting was that across all of their different 4 categories, breast satisfaction, psychosocial well-being, physical well-being, and sexual well-being, patients who had a unilateral lumpectomy or a one-sided lumpectomy, and that's here shown in green, had higher overall satisfaction scores in all of the different categories. And that's very much different from patients who had bilateral, so both sides, or one-sided mastectomy, so removing all of the breast tissues. Those patients who had mastectomies actually overall across all categories had lower scores. They actually, whether you had one mastectomy on one side versus both sides of your breasts, the scores were relatively similar in terms of their well-being and satisfaction. And so really, women, when they're offered that breast conservation, just having that lumpectomy did tend to have better well-being scores and breast satisfaction. which was really interesting. I think a lot of times as providers, we tend to think that women who want the bilateral mastectomies for different reasons, whether it's being afraid of their cancer coming back or having to do frequent MRIs or mammograms, and the anxiety that that could provoke could also actually lead to lower scores. And it seems like the breast conservation is really benefiting women. So when they looked at different factors such as younger age, they noticed that women diagnosed at a younger age tended to have lower psychosocial well-being scores, lower physical well-being. They tended to have more distress and anxiety and depression. Patients undergoing chemotherapy had significantly lower sexual well-being scores. Patients who were able to achieve a pathologic complete response, so those getting treatment before surgery and actually with their treatments were able to make their tumors melt away, had lower anxiety, which was great. And actually radiotherapy, you know, they had patients undergoing that had lower breast satisfaction and psychosocial well-being scores as well. Patients with triple negative disease had lower breast satisfaction and psychosocial well-being scores, and much more distress and anxiety and depression scores. Patients undergoing endocrine therapy, you know, oftentimes we think of it as a simple treatment with a daily pill. They actually still had lower sexual well-being scores as well, and significant distress and anxiety. In a separate analysis that these authors were able to do, what they found overall at that 12-month mark, so 12 months after surgery or after their treatments, surgical procedure, the type of surgery they had, was actually the most important predictor of breast satisfaction, psychological, physical, and sexual well-being. Patients with HER2 subtypes, having that HER2 subtype alone did predict a worse breast satisfaction score, psychosocial, physical, and sexual well-being. And income level actually did play an important role in predicting breast satisfaction and physician well-being, as did marital status at that 12-month mark with predicting sexual well-being. And ethnicity and education level did also help predict the amount of distress that patients would experience at that 12-month mark, so 12 months after surgery. So overall, in conclusion, they found that psychosocial functioning after breast cancer treatment is not only influenced by the treatments that we administer to patients, but really is an interplay of their different patient factors, socioeconomic factors, income level, tumor biology. And in particular, what the authors found was that income level, education level, and marital status predicted certain psychosocial outcomes at 12 months after surgery. And this really gives us identifies for us important modifiable factors that we can actually try to do better in as physicians treating breast cancer to help our patients have a better overall experience and treatment outcome with their well-being.
Oh, that was great, Theresa. Do you have a sense about why ethnicity played such a big role?
You know, I don't, and I often wonder whether it's about the ability to have more of a community inclusiveness, the connections people are able to make. So whether in the future, different outlets such as Twitter or Instagram can help kind of connect different social groups that certain minorities might feel a little bit more isolated from other members across the country having that same diagnosis. But it's a really great question that I think the authors will probably be looking into in future studies.
Do you know if they looked at whether the sexual well-being by whether based on sexual preference? I think that's the right way to ask that question.
Yeah, no, I don't think they specifically delineated that in particularly their abstract here, but also, you know, really interesting questions with, especially with the chemotherapy and endocrine therapy scores that they had for sexual well-being.
Yeah, I think that would be really fascinating to look at as well. It seems like this is an area where there's a lot of room for looking more. And I think it's fascinating that surgery per se plays such a big role,
Right.
particularly in patients who have mastectomies and still need radiation therapy, where quality of life can really be adversely impacted in a big way.
Definitely.
And then, well, you know, that is just one quick question for you, Michael, is that you know, I have patients sometimes see me who say they're all ready to get a mastectomy, they don't want to deal with cancer again, but I know that they had positive lymph nodes or cancer in the lymph nodes and they will need radiation therapy. I've been very big on saying maybe don't think about doing a mastectomy if you know for sure you could need radiation, and you could have a lumpectomy simply because of the complications after mastectomy with reconstruction. What are your thoughts on that?
Yeah, no, that's a great point. And Dr. Chan and I have been talking about this in multiple times in clinic and patients that we see about, as just like you said, this data really shows interesting because you'd think that, oh, well, more women are going to start choosing lumpectomies, or, more women should be choosing lumpectomies because it may be a better quality of life. But what we've seen is the opposite in the last 10 years, or, the more mastectomies, more bilateral mastectomies. And you're absolutely right, especially when it comes to those patients that have a high chance of having a complication with radiation and mastectomy that can have a lumpectomy. Really try to get them to see past the scariness and the anxiety that they might have regarding the possibility of, the cancer coming back, when we've shown, and you as well, and the rest of the group in our own data, that whether you have lumpectomy or mastectomy, you have the same chance of it ever coming back. So it really is something that we try to have patients say, oh, well, go home, talk with your family, your friends about it. And before making this ultimate decision, take some time to think about it. And that's why it's always great to have them see plastic surgery well before, radiation surgery before. And it just really shows that the multidisciplinary aspect of, making sure that they see the oncologist sometimes about, even if they're kind of borderline neoadjuvant patients, that, bringing in the multidisciplinary team is hugely important. And things get missed sometimes because you're not including everybody in the consultation until after the fact, unfortunately. So it's totally great question.
Yeah, of course, some women will need to have mastectomies regardless because of the extent of disease. And we're really talking not about little tiny cancers, but cancers where you need radiation. And that may create issues in terms of the blood supply and healing with mastectomy and reconstruction. So Natalie, as we're all sitting here, and I've been sitting, I think now for 12 hours, tell me about muscle mass. You're on mute.
I'm just going to show a few slides. There's an abstract about overall and disease-free survival in patients that had low muscle mass and low muscle density and intramuscular adipose tissue. And this was looking at young
Adipose
patients.
is fat tissue.
Yeah, adipose is fat. I have that like in parentheses there. Wait, sorry. There we go. So these were patients that were less than 40 years old. Median age was 35 years old. And what sarcopenia means is low muscle mass. So low muscle mass. And then they showed that if you have low muscle mass, that you had a lower progression-free survival. And that if you had intramuscular fat or low muscle density, you had lower overall survival. So I want to just show you a quick picture about what that means.
Define progression-free survival, and it's actually complicated, but it means if your progression-free survival is generally used in somebody who already has cancer that can't be cured, or metastatic cancer, as opposed to early cancer, and it means how long your disease stays controlled on any one treatment.
Thank you. So this is looking at two patients with the same body mass index, and that's a measure of your height and weight, and they use it as a surrogate for being overweight. But if you look at these two pictures, these two patients have the same muscle mass, but this patient over here, the red is actual muscle, and the green is fat that's infiltrating the muscle. So this patient over here on the right has much more muscle mass, less sarcopenia, and not very much fat within the muscle. So they have good quality fat, good quality muscle. And on the left, you can see that there's intramuscular fat in here. And this is actually poor quality muscle or low radiodensity muscle. And so in looking at these patients, what they found was people that were like the people on the left, lower muscle mass and poor muscle quality, they had a higher risk of their cancer progressing a shorter period of time before their cancer would progress, and they also had a lower overall survival. And this was a study that was done at Kaiser that showed in breast cancer patients that had low muscle mass at presentation, even though they didn't have metastatic disease, had a lower overall survival compared to those patients with normal muscle mass or not sarcopenic. So why I think this is an important study or poster, why I liked it, even though it's not a huge amount of patients, it was only like 109 patients, I think. But what's important about it is that people need to exercise and try to build muscle mass, because that's something that is an indicator of overall good metabolic health. And we know that metabolic factors can affect breast cancer and breast cancer progression. But this is just
Natalie, was
another.
that study done in metastatic breast cancer, because they talked about progression-free survival?
Some of the patients were metastatic at presentation, and then most of them were not. But this is looking over time at the patients that became metastatic, their progression-free survival, and then overall survival that's breast cancer specific.
It's interesting because there was a lot of fat in the abdomen in that one CT you showed, and that kind of fat that's inside your abdomen is problematic too, I think, to your general health, not just to your cancer health, which is interesting.
True, because it's associated with diabetes and cardiovascular disease and other things that cause an increased risk of death as well.
Somebody asks if there's too much fitness, like, how much muscle is ideal? When is the situation where somebody's exercising too much? Of course, Michelle, they're sitting at the beach, the beach just south of San Francisco, is shaking your head no. She's a big exercise enthusiast. So maybe, Michelle, why don't you answer that question? And also, then how do you test muscle mass for you, Natalie? Michelle. So Michelle, you're on mute.
Yes, I'm sorry. I just was laughing. So, as far as humans go, I think in our breast cancer population, there probably isn't a place where there's too much fitness. I do think that in, elite athletes, they can, get carried overboard and end up with joint and injuries, and playing sports that are, when you're not trained to do them, could be dangerous or could involve injury. But I think that for our population, I don't think anyone's going to reach a point where they're doing too much cardiovascular, too much strength training. I think I mentioned on one of these calls before, one of the forums before, there was a really interesting thing that Lee Jones did. He's a big exercise physiology guy, talking about, the exercise prescription, that there may be certain types of exercise that are better than for some people. And that they showed a study, which I'll never forget, where he was showing that they made these rats, swim without in a pool where they couldn't do anything but swim. I mean, they basically swam them till they drowned or close to drowned. And, they did then measure impact on, stress markers like adrenaline and, inflammatory markers. And there is a point where, the rats that they made swim too long, it seemed like it was bad for their body. But I really don't think we ever get there with humans. That's my opinion. So
yeah, I will say that there is some data that suggests that if you're very low on your body mass index, you have a similar poor outcome than if you're very high on your body mass index.
Yeah. No, I mean, Betty Kahn's data, some related to much of the data that she's presented shows that there is this kind of sweet spot for BMI, that if your BMI is, below something like 17 or something, that's not good. Even, so basically it's best to be normal. Between 20 and 25. But in terms of measuring it, I think that's a really good question, because you noted on that scan that there is all the subcutaneous fat. So, should we be measuring, total body fat? Should we be measuring intramuscular fat? I don't think that BMI is probably that great. Some people, like me, just genetically, I'm a really muscular person. And so I have a pretty high, BMI. I don't think I'm fat, but most people don't think I'm fat, but I have a pretty high BMI for, just because I'm pretty muscular. So I think that's something certainly that is going to be important to look at. I mean, in terms of understanding, everybody wants to have something that they can impact in terms of lifestyle. And lots of people spend a lot of time on their diet and eating organic and cutting out this and cutting out that, taking a lot of supplements. And I'm a big proponent to say that exercise is the only lifestyle change, really that has consistently made a difference.
And then DEXA scans can be used to look at body composition. But basically the message is you don't have to go get a CAT scan, but you should exercise and do some form of strength training. And that's
how
the
do you-
American
how do you
guidelines
test,
for.
Natalie, how does a person test muscle mass?
The best ways and studies have been through CT scanning that they've done at baseline when the patient's diagnosed.
And
But
then
we're not going to do
how-
CAT scans
you
on everybody.
mentioned bone density. Can you go talk about that a little bit more? Is bad bone density a predictor of bad outcome?
No, there's DEXA scans for body composition, looking at your muscle mass. It calculates your muscle mass and your fat mass, and they're about $35 to get.
Yeah, so this is not the bone density that you get for your bone density to see if you need a bone strengthening agent on an aromatase inhibitor.
No,
Now, this
and
is
they do offer them at UCSF.
Yeah, so you can get them. We don't order them, but you could get them if you needed it. So Michael is also exercises a lot bikes, and so we have actually good representation. And Natalie, as I think many people have heard before, has actually an app for exercise and strength training, which we'll see more and more of, I think. So on that sort of happy news about exercise, which I think is kind of happy news, is and that's something we can do really proactively for ourselves. Not that I'm exercising enough, but I do believe in it. We were going to talk a little bit about triple negative disease and neoadjuvant therapy using immunotherapy, kind of two different approaches. And now we have Joe Chen with us. Thank you for joining us. Joe, you could, if you're ready, we could have you talk. And then there was a question from the very beginning about treatments for metaplastic breast cancers. Somebody had asked just before you start about whether or not you have that exercise data for women who are, over 40 or over 60, and that doesn't exist really in terms of breast cancer outcome, except for BMI. Being obese is a poor factor. Joe.
Thank you. Sorry, I am late. I guess I am the panel member that does not exercise. So I'm here to represent the anti-exercise cohort. I'm glad I came in when I did.
Right.
Okay, so let me share my screen. So as, okay, hold on. Okay, you can see that?
Yeah.
All right, so I'm going to talk about a couple abstracts if I have time, but the main one is looking at immunotherapy in combination with chemotherapy in the neoadjuvant setting in patients with early breast cancer. There's been a lot of work in this field lately. The idea with immunotherapy is that your body has ways to check your immune system so it doesn't react to normal host cells, right? And what oncologists and scientists have been trying to do is to release those checkpoints in order to stimulate your immune system in order to attack cancer cells. And we have seen in a number of studies now how chemo and immunotherapy can be synergistic, and specifically in the metastatic setting for triple negative cancer, there is good data that immunotherapy can prolong the time that your cancer is responding for patients who have a specific biomarker called PD-L1. This study is looking to see, well, can immunotherapy benefit early stage breast cancer? There have been 3 big studies, but this slide really just summarizes the 2 big ones. One is Keynote 522, looking at the drug pembrolizumab, which is Keytruda with chemo versus placebo and chemo. And then Impassioned 031, which is looking at atezolizumab with chemo versus placebo and chemo. In both of these neoadjuvant trials that are randomized phase 3 trials, they saw higher rates of what we call pathologic complete response, meaning a higher percentage of patients who have a complete response to treatment before surgery. I mean, we get to surgery, there's no invasive disease. So the group that had the immunotherapy had higher rates of PCR than the group that did not get immunotherapy. And this was true whether you had this biomarker PD-L1 or not, which seemed to be required for benefit in the metastatic setting. We're not seeing that in the early stage setting. These two trials have reported out on long-term prognosis. And in 522, there was a recent press release, this is the pembrolizumab study, that they do see improvements in long-term survival. We haven't yet seen the final data for that, but here are results from an early analysis showing that there was numerical benefit in long-term survival with pembrolizumab and chemo versus placebo and chemo. And in the Atezo trial, not statistically significant long-term survival, and that data is maturing. So this study is looking at a third immunotherapy, which is durvalumab with chemotherapy versus placebo with chemotherapy. And they randomized 174 patients. They were all triple negative. And they got a full sort of 6-month course of chemo plus or minus durvalumab. And then they went to surgery. And their primary endpoint was just to look at pathologic complete response, similar to the Keynote and the Impassion trial that I just talked about. And they also looked at the long-term survival. And in this presentation, they reported out on the long-term survival. They previously reported already the pathologic complete response. So previously they shown that yes, there was a numerically higher complete response rate with the durvalumab and chemo compared to placebo, but it wasn't statistically significant. I'm going to skip this slide. So here they're going to report out on the long-term prognosis, and that is the most important, right? We really want to know that these patients have fewer recurrences, not just that they have higher rates of complete response. And what they did show is that yes, there was better long-term prognosis, and in terms of the events that were improved, it was really the distant relapse. So the pink bar is the group is representing the durvalumab, and the green in placebo. And you can see there were more distant relapses in patients who got placebo versus durvalumab. And that's always a good sign, because what we care about most is that we're reducing distant recurrence. We care about the others, local, regional, and contralateral and second malignancy, but the most important is to reduce distant relapse. And I like this slide, 'cause it kind of puts everything on one slide. So Hope had talked about previously invasive disease-free survival, which is looking at recurrence, but it also includes local recurrence as well as new cancers. The middle panel here is distant disease-free survival. That's the one we really care about, and ultimately overall survival. And you can see there, the pink curve represents the group that got durvalumab, and the blue represents the group that got placebo. And you always, in these types of curves, are called Kaplan-Meier curves, you always want to see a separation, because that tells you there's a difference, that the intervention you gave made a difference. And what you want to see is that the intervention gives you that the line is higher, right? So the patients did better. There were fewer events when the line is higher. And you can see for all invasive disease-free survival, distant disease-free survival, and overall survival, those lines are separate. And that tells us there were fewer distant relapses and fewer deaths in patients who got the durvalumab. What is really interesting, though, is in addition to that, they also looked at the patients who did not get PCR. So without getting too detailed, we know that if you get a complete response, you will do better in the long run, because you'll have a lower risk of recurrence. In the group that had a complete response, if you got durvalumab, you still did better than those who got placebo. And if you look at those who didn't get a complete response, those that got durvalumab still did better than those who got placebo. So it seemed that you potentially could still benefit from the immunotherapy, even if you don't get a complete response. So that is something that we need to continue to monitor and watch, but I think that's a really exciting finding from this trial. So, and this is just another way of presenting what I just said. I think there's a few take-home things from this trial. One is immunotherapy certainly can improve complete response rates with chemotherapy. And now this is the first trial that has presented data showing that that translates into lower risk of metastatic recurrence as well as improved survival. But it's also saying, you know, patients who didn't achieve a PCR also benefited. And perhaps PCR isn't the only way, isn't the only biomarker to assess benefit from immunotherapy, right? We know in chemotherapy, with chemotherapy, that PCR or no PCR is very prognostic. And that's still the case here. But I think when you add immunotherapy, there may be other things that we have not yet, that we don't fully understand, that might reflect response that is not fully reflected in PCR. So I'll stop there and hope. I know that we are short on time, so I don't know if you want to discuss SD101 or you want to move on to something else.
Yeah, I think that it would be nice. You don't necessarily have to show slides, but I think it'd be really interesting to just briefly talk through you know, it's an I SPY arm, and I think it's really important. I think there was a question that came in, PD-L1, did the trial require patients be PD-L1 positive? And across the neoadjuvant trials that showed a benefit in PCR, which this one didn't, it was seen regardless of PD-L1 status. And they looked actually at tumor infiltrating lymphocytes in this trial, and they also didn't see a difference in the rate of PCR. So it's interesting. I mean, I think this is quite intriguing data. But, you know, it's interesting. So now you have, you know, some data that maybe you can improve outcome even when PCR is not improved, but you don't have to give a whole year of checkpoint inhibitor therapy. You know, it's 172 patients versus almost 1,200. I don't know. I mean, do you think that the future will be giving a year of checkpoint inhibitor therapy for patients who have triple negative breast cancer that's at least stage 2?
So I definitely don't think, we'll have to see all the data that are presented from all the different trials, but I don't think 1 year is necessarily going to be needed, since in the trial that I just presented, it was 6 months. I think we really have to think about the toxicity, and that is something that the immunotherapies, in terms of toxicity, obviously it's not like chemotherapy, so there isn't as much impact on the counts and nausea and diarrhea for the most part, but there are immune-related toxicities that are quite significant and can be irreversible and permanent. And so these are real toxicities, and they're real risks, and I think that's going to be the challenge to figure out for whom it makes sense to take on that risk. In the SD1, this other abstract that we mentioned, we actually combined a second immunotherapy with pembrolizumab and chemotherapy, and we injected this second immunotherapy. It's called SD101. We injected it directly into the tumor. We gave the pembrolizumab with the chemotherapy, and what we found is that it did improve PCR rates slightly. But what was really remarkable is that it increased the immune toxicity significantly. About 35% of patients developed an immune-related event. That's much higher than what we have previously seen in other studies. And so I think there's still a lot to learn on certainly immunotherapy-related toxicity, but how do we combine them together and with chemo in particular? So, you know, in that study, 13% of patients had an irreversible adrenal insufficiency that required long-term steroid replacement. So it's not benign, and but I think that immunotherapy will be incorporated in early stage triple negative treatment in some way in the future.
So yeah, I agree with you. And there's trials going on looking at it in patients who got surgery first, although we are generally discouraging that quite strongly in triple negative disease, and big adjuvant trials going on in international study. And then there's another larger neoadjuvant trial. So there will be a lot of data coming up, but I think this data, which we expect to see this summer from Keynote 522, will be important. But it's fascinating that by adding another immune therapy that should improve the response, that you actually just got more immune toxicity, which is, maybe, we don't know if we should be giving just once or we should be giving in a different order. It's very hard to test that. And it is really interesting. I think I'll ask a question in just a moment. But for one, somebody had asked about treatments for metaplastic cancer. Michelle, do you treat metaplastic cancer differently?
No, I mean, I wish that we knew something better and different. We know these cancers tend to be very chemo resistant, and a lot of the patients, do find their way down to MD Anderson because, prior to her departure to go to Lilly, Stacy Mulder had a program there. And, there were recommendations that she would make for these, sort of novel cocktails of therapies that we couldn't get authorization for in the early stage treatment setting. So it is a hard thing because, they with standard, AC Taxol plus carboplatin, I haven't seen great responses. But what has been interesting on my just, sort of N of 3 observation and maybe the last year and a half of metaplastic patients is that they often can be resectable, that even if the tumors are quite large, they often, the surgeons can get them out. But sadly, some developed, lung metastasis or other sites of distant metastasis very quickly. So clearly, I think this is a case, the metaplastics, where sending, something like a UCSF 500 on the, the tumor that's resected, even if not metastatic, hopefully we could start to see some pattern of molecular markers that could be seen as a target. But right now we don't have anything different necessarily to offer them. So I do treat them the same, but I wish I had something different.
Yeah, I agree. And I think that, Stacy was working on mainly using a variety of other toxic combinations. And there is a metaplastic support group out there in the US that we've worked with as well. And I think there's a lot of interest in the immunotherapy in the metaplastic group, but it's unclear exactly how to make it work in the best way. We do have a study looking at trying to enhance the effective immunotherapy in metastatic triple negative breast cancer through our consortium with the drug Trodelvy or sacituzumab govitecan, as well as others that should be opening shortly. So that's another interesting area. We're now at 7:30 and, we have so many things that we could talk about, but I thought we would just close with a sentence or two from each person about their big takeaways from ASCO and what you're looking for. Our next, we have the European Society of Medical Oncology in September, and then we have the San Antonio Breast Cancer Conference, which might be our first face-to-face meeting in 2 years in December. What are you looking forward to from these meetings coming up in the fall? Joe, do you want to start?
Sure. I'm really looking forward to, and I don't know when these data will be presented, you might know, Hope, is updates from the Monarchy trial, which is the trial with the CDK4/6 inhibitor, abemaciclib, in high-risk patients in combination with hormone therapy. We've seen previously that with early short follow-up, we're seeing some benefit, but it's important to see how that plays out in the long term.
I think we'll see our next update in 2022. So a little bit longer. Natalie?
I was excited about the PARP inhibitor data. And I'm excited about being part of I-SPY so that maybe we'll be able to use a PARP inhibitor in the neoadjuvant setting.
And we're excited about having you be part of I-SPY and offering treatment to patients in the East Bay as well. It's great to have you part of our team. Michelle?
I'm always trying to look for something, new and hopeful in the area of CNS disease. And although we didn't get to talk about it.
Briefly mention?
No, I think I think it's probably best we could save that for another forum. But I think one of the things that I won't go into the data, but briefly there is definitely an interest in trying to identify patients of particular biology, particularly triple negative and HER2 positive, that have, we know that these patients, even when we have really great control of their systemic disease, they can develop brain metastases. And there was some great data that was presented, actually kind of shocking data about how successfully we might be able to predict the development of brain metastases in the triple negative population. The challenge is that we don't have great agents. And so what I'm looking forward to seeing and hoping to see more of are, companies that have antibody drug conjugates, that have novel, therapeutics, small molecules, be willing to test them in patients with both stable and progressing brain metastases. So I know that trastuzumab deruxtecan, has data that's emerging and growing in the HER2 positive population. I'd love to see what comes out with sacituzumab govitecan in terms of its ability to penetrate the brain in some patients. So I'll be waiting to dig through the abstract to see if anything shows up there at San Antonio.
Great. Yeah, I think there was a question about new therapies for hormone receptor positive disease. And, we have the oral selective estrogen receptor degraders, which we'll see phase 3 data, and maybe by San Antonio, certainly next year, from at least 2 trials, lots of different combinations being studied. And these will rapidly, I think, move into the early stage setting. And we're really excited about the endocrine optimization protocol that Joe Chen is running, a national multi-center trial looking at an oral selective estrogen receptor degrader like Faslodex, the injectable drug, but that's given as neoadjuvant therapy in combination with different agents. So that's a very exciting trial for us. And we're excited to have it to offer patients who have hormone receptor positive early stage disease. But SERDs are big. And I think we'll see a lot more of other targeted agents too, in hormone receptor positive disease and antibody drug conjugates in hormone receptor positive disease in the next year or so. Michael.
Well, I think obviously all of the things that you all do that make my surgeries much easier and less complicated. So all of the data that, shrinks tumors and things, but, kind of commenting on what I shared with the group earlier about patients that have lumpectomy that might be able to not need radiation therapy. I think, for those patients that actually do end up getting mastectomy and maybe do have a positive lymph node, really trying to find out which women don't need radiation in that setting, because the rates of complication go up dramatically. All of the stuff that Theresa Chan was showing about quality of life is going to, go down with radiation after mastectomy. So if they can take this gene signature, genomic assay, fingerprint, whatever you want to call it, and actually maybe also apply it to those women that have had mastectomy that are needing radiation. I think, avoiding radiation and de-escalating, Dr. Rugo's new word that she loves so much, that would be great as well.
Yeah, that's great. Everybody's done such a beautiful job. And I think that, when we have our next forum in the end of September, we'll not only be able to talk about some of the information from the European Society of Medical Oncology, potentially the Keynote 522 data from the summer, and also some other interesting data we didn't have time to talk about using the MammaPrint assay or another assay called the HI index to try and understand who needs even less therapy. So, we do get that comment from the physician who doesn't like me using the word de-escalating, is optimizing. So we can try and use the word optimizing. Thank you for bringing up a suggested word. So all good. And thanks very much, you guys. You did a fabulous job. And to Melody, as always, for organizing this. And we look forward to seeing you in September. Be safe. Have a wonderful summer. And see you soon, and we all can exercise more. Take care, everyone. Bye-bye.
Thank you. Thank you.